Hi, welcome to You Didn't Get the Memo show. I'm your host, Gloria Bailey Ray, and I'm excited as always to come before you and bring you fantastic shows. Today, we got a great one for you. So, I want to make sure that you guys get all of your relatives, your friends, your family, gather them around because we're going to be talking about colorectal cancer. Um, so let me start with, first of all, for those of you who are new to You Didn't Get the Memo show, let me just share with you that this is a show that's about providing you, the viewer, with relevant, factual, mainstream information to help you be informed and to make informed decisions. I'm excited to share with you that today is our first airing live on LinkedIn. So, in addition to You Didn't Get the Memo being on Facebook, YouTube, we are also live on LinkedIn. So, welcome to all of those new viewers there. If you have questions or comments, you can place them in the comment section. We'll do our very best to get to you and respond back as quickly as possible. Our show today is brought to you by Ms. Joyce Van Hoof of Golden Memorial Insurance Services. And my guest today is Dr. Ralph Peterson, who is a gastroenterologist. We're going to be discussing colorectal cancer and preventative measures. Before I introduce Dr. Peterson to you, just want to kind of level set and want you to let this sink in. And that is, according to data, colorectal cancer is the second leading cause of cancer death in the United States for men and women combined. But also, it's the third leading cause of cancer death in men and the third leading cause of cancer death in women. So I want to welcome to the show Dr. Ralph Peterson. Dr. Peterson, thank you so much for joining me on You Didn't Get the Memo. I'm excited to talk to you, and I'm certain that viewers have questions for you as well. So welcome to the show.
Thank you for having me.
You're very welcome. So let's start with this, just a little bit to give our viewers some idea about your backstory. Like, where did you go to medical school? What inspired you to be a physician? And in particular, why gastroenterology? So let's start with that.
Well, born in Oakland, went to all the schools in Oakland, James Madison, went to Skyline High School, went to UC Berkeley, and then from there, I got accepted to Howard Medical School. After spending a year at Children's Hospital doing some work there, I said, "Oh, I need to get into become a doctor." My major then at UC Berkeley was biochemistry. Initially starting off in engineering, then switched to biochemistry and said, well, I think I want to become a doctor, become independent, so I won't have to work for anybody. I can work for myself. So I got accepted to Howard Medical School, and I was really surprised because of the wealth of knowledge that I had seen there with those brothers and sisters back in the early 19th century. I said, wow, this is some history here. So I was happy to go to Howard. And after being at Howard for a while and then doing my internship and residency there at DC General Hospital, I ran into some very dynamic Black gastroenterologists. And I was so impressed that I said, that's what I want to become. I became a gastroenterologist because of them. And after I finished at Howard, which is in Washington, D.C., I just came back home to Oakland. And I've been in Oakland practicing in private practice since 1983, initially as an internist and then as a gastroenterologist only.
Oh, okay. Awesome. Well, you're the right guy that we want to talk to because let's start out with just talking about what is colorectal cancer. And then I want us to get into, because one of the things you and I had a dialogue about was someone very well known, Chadwick Boseman, who actually passed away at a very young age due to colorectal cancer. So let's just start with, what is colorectal cancer?
Well, colorectal cancer is an abnormality in the tissue. The tissue, for some reason, go astray and start making cells that it should not be making, and those cells continue to be multiplying and dividing, multiplying, dividing. Next thing you know, you have either an obstructive process or you're bleeding and you're losing weight, you're losing appetite, you're wondering what's going on. And then we do an endoscopic procedure because of your presentation at that point, and we find that you have colorectal cancer. So it's an abnormality in the tissue that we don't know why it happens, but it's an abnormality. There's a lot of theories about why it might happen. For example, we see a lot more colorectal cancer in African Americans. We see a lot more colorectal cancer in people who are heavy drinkers, smokers, people who eat less fiber, eat more fat, more meats. That's when we tend to see colorectal cancer. People have a family history of colorectal cancer. That's another set of people that we see colorectal cancer in. So there's multiple reasons why, but we really can't hang a hat on exactly what precipitates colorectal cancer.
Okay, so let's talk about then age and ethnic groups. You start out. You said that it seems to be more prevalent in African Americans, but when we talk about age, what seems to be the age now that maybe you are seeing that seems to be affected most by colorectal cancer?
Ooh, that's a tricky one. If you look at the past, that's tricky because we say 50 and older, and there's no
Right.
question when you get 50 and more, you tend to have more polyps, and then polyps turn into cancer. So there's no question about that. But if you look at from studies from 2002 to 2000, 2000, 2002, all the way to 2014, there's been a 15% increase in people with colorectal cancer who are between the ages of 40 and 49. In fact,
Oh,
there's other studies that said that there have been an increase in colorectal cancer in people who are from 20 to 40. So when you start talking about age, it's a moving target. The American Cancer Society recently reduced its requirement for doing a colonoscopy from 50 to 45. The United States Public Service Task Force also came on board and recently reduced theirs to 45 as well. So 45 and above, we recommend doing a colonoscopy on patients.
okay. So I mentioned Chadwick Boseman. And you and I have had this dialogue back and forth. And like you said, it seems to be a moving target, but especially among African American men. I guess I just wonder, and I don't know if you have an answer for this or not, but I just wonder if Chadwick had screening earlier on, as opposed to because the screening started out with the, 50 years of age, and then they moved the marker back to 45. So
Yes.
hearing you saying, and I'm thinking, especially among African American men who tend to not go to the doctor as often as maybe women do. But what are your thoughts about moving that back? Because in my mind, I'm thinking 30, 35. Diet has changed. You mentioned something about fiber and things. And so there's just been a whole shift around a number of things that maybe you and I grew up with. So what are your thoughts in regards to that changing that target? It needs to be moved even to a much younger age group.
Yes, there's no question in my mind. In fact, in my office, I call it save your butt. In fact, I'm very radical about it. I think that, in fact, I know 45 is too late. 45 is good for a colonoscopy, but and we'll talk about the different tests to look for colorectal cancer. And one test, which is very cheap, is called a FIT test. It's a fecal immunochemical test, and it's an antibody test to look for hemoglobin in the colon. So if you're bleeding in the stomach, the acid in the stomach might break down the hemoglobin, and so therefore that FIT test won't be positive, should not be positive. So it's looking for whole hemoglobin. So really, you should start at age 30. You should do a FIT test every year on your birthday. I call it save your butt. Save your butt on your birthday. You want to live a year longer because your butt is the one that's on the line. Nobody else's butt is on the line but yours. When you get colorectal cancer, it's personal. It's you that have it. And so if you start at 30 doing a FIT test, which is inexpensive, it's like $1.50 a month to save your life, $15 a year, it's worth it. So if you did a FIT test every year on your birthday until you're 45, starting at 30, and it remains negative, then you have your first colonoscopy at 45. You see, colonoscopy, there's no question, is the gold standard because
Mhm.
we're actually looking at the tissue. We can remove it. We know where it's located. So colonoscopy is the gold standard, but the FIT test would give you an idea if we should even proceed down that road if you start at 30 years of old. Now let's come back to Chadwick. Chadwick died at 44. He went into
Mhm.
the hospital around 39, 38 years of age. What did he go for? Bleeding, weight loss, probably not understand weakness and pain. So when he goes to the hospital or goes to his doctor for that reason, the doctor say, hey, let's do a colonoscopy on, and they found colorectal cancer in a later stage. And we'll talk about staging later. the stages later, because we know that most people, 20% of the people present with metastatic cancer by the time they even come to us. So you want to catch this early. If he had done it at 30, they would have found blood in his stool. They would have done a colonoscopy maybe at 30 or 31, and they would have found cancer at an early stage, which is curable. It's curable at that if you catch it early. So that's what's important. If I had to leave a message, that would be my message for everybody to take away from this show. Start early. 30 is a good number.
Okay. All right. We have a question from one of the viewers. They wanted to know, should a woman be concerned about colorectal cancer?
Let's put it all in perspective. First of all, we all humans. On the inside of his body, all look the same. I want to make sure that's very clear. It is the same on the inside. Now, if you look at the data, if you look at who get cancer in women, what kind of cancer does one get? Number one would be breast. Number two would be lungs. And number three would be colorectal cancer. If you look at who dies in a woman from cancer, what kind of cancer causes death? Number one would be lungs. Number two would be breast. Oh, by the way, colorectal cancer is very close to breast, is number three. So should you get screened knowing that's the third leading cause of cancer death in female is colorectal cancer? Absolutely. No question. It might surpass breast.
Right. Oh, wow. That's awesome. We have another question from one of the viewers, Dr. Peterson. They wanted to know, should high risk be every 3 years if you've had family members with cancer? And thank you guys so much for your questions. This is the opportunity for you to weigh in and get some answers. So, Dr. Peterson, should high risk be every 3 years if you've had a family member with cancer? Let's see. All right. Are we frozen there? All right, seems like that we're frozen here for a minute. You guys know how technology works, so let's keep it moving. We'll
I'm
get
back.
Dr. Peterson back. Okay, thank you so much. So, did you hear the question? One of the viewers wanted to know: should high risk be
You're not
every
in it now.
years if you've had family members with cancer?
Check it out.
All right.
Connected. We're connected. Okay. Here we go. Okay. Hello?
All right. Yes, we can hear you. Okay. Well, you guys, there's always something that comes up. So I'm certain that Dr. Peterson will get him back in and back on. But thank you so much for your questions. And if you guys don't mind, some of you just let us know where you're tuning in from. That would be great. I see that the women's chat group is on and is here. So Dr. Peterson, hopefully we'll be able to get him back. And thank you so much for standing by. I appreciate that. We're definitely going to get a response to your question. No doubt about it. Okay. So thank you for that. All right. So as you can see, we lost communications with him, but I'm certain that we'll be able to bring him back. So in the meantime, thank you for checking in from Fort Hood. I appreciate that. Let us know where you are. We'll get Dr. Peterson back online just as soon as possible. And we'll go from there. But I love the fact that you guys are asking questions, because this is information that we really I think that it is valuable that we have and that we know. So let's see. All right. Thank you, Miss Deborah, Bay Area, checking in. I see some of you others, let us know where you're checking in from. And we're trying to get Dr. Peterson back online and see what's happening. So I tell you what, we're going to take a quick commercial break. We'll be right back. Don't you guys go anywhere, okay?
Let's get back to talking smack with the side of mac and cheese.
Before we can safely come together, we need the facts on COVID-19 vaccines.
To get the facts, visit getvaccineanswers.org so you can make an informed decision when vaccines are available to you.
Home fire drills give your family a plan of action. Show everyone 2 ways out of the house, pick a safe meeting spot, and get there in under 2 minutes. Then practice so everyone knows exactly what to do. Go to ready.gov/fire drill and learn how to prepare your family.
All right, we're back. We got Dr. Peterson back with us. Some technical difficulties there, but Dr. Peterson, there were a number of questions, so hopefully you can hear me. And we'll start with the question about high risk. Should it be every 3 years if you have family members with cancer and considered high risk?
Yes, that is one of the high risk category. If you have family members with cancer, in fact, this is what you should remember about that. Let's say a parent developed colorectal cancer at 48 years of age. That's when they detected colorectal cancer. He may have had surgery, may have had chemotherapy, he got treated, he's doing well. That means all the kids should be screened 10 years younger for colonoscopy. So they should be screened starting at 38. That's when they should be screened because they're in a high risk.
All right. We have another question from the viewer. They wanted to know if the FIT test, is it conducted by a physician or is it something that they're able to do at home?
Oh, this is something you do at home. You can in fact go to Pinnacle, Pinnacle, Pinnacle. I have no stock in the company, which I did. But you go to Pinnacle Labs and you can order the FIT test, the fecal immunochemical test. They'll send it to you. You get 2 of them for $29. You can get 20 for $100. Good Christmas present to give your people that you love to keep everybody alive. Right. Great Christmas present. And you do it at home. It comes with a little jar. You take a little brush out of this little jar, swish it around in your stools, put it back in the jar, shake it up, and drop that solution into a well. You will get 2 lines. If you get 2 lines, you will have trouble. That means you have a problem. If you get 1 line, that means you're normal, you're okay. Do it next year on your birthday. Save your butt on your birthday. That's the point. Yes, you can do it at home.
Okay. Hey, thank you guys so much from YouTube, the questions. I love it. We have another question before we move on. Should one get a second opinion? This gentleman wants to know, should you get a second opinion?
Well, if I tell you have cancer, I don't know what the second opinion is about. Usually, if I perform an endoscopic procedure, take a biopsy, I think it's cancer because it looks like a cauliflower, looks a certain way. I say, ooh, this is cancer. I send it to the pathologist. They make a diagnosis of cancer. And believe me, they're very hesitant about making a diagnosis of cancer unless it's obvious. So when I get that diagnosis back from the pathologist, that is the second opinion. You have cancer.
All right. So thank you guys so much. Keep the questions coming and shout out to, we got Atlanta, San Antonio, Little Rock, all of you guys in the house. Thank you so much for tuning in. So Dr. Peterson, you've talked about how colon cancer is detected, how you diagnose it. But here's the thing. Let's go back to something you said early on. I want to make sure that people understand this. The question is colon cancer treatable and or curable? And I think that that's one of the things that people need to understand. Just because they've gotten a diagnosis, probably if it's caught very early on, that it is treatable. But we want to hear from you. What are your thoughts about colon cancer being treatable and curable?
Yeah, here's the facts. Let's talk facts first. 1 out of 3 people go get screened for colon cancer. That's fact number 1. Most of the patients who present to us for colorectal cancer, 20% of them already have cancer in the liver or in the lung. Usually the liver is the first spot that cancer will go to. So by the time you come to us, you make it very difficult for us to cure you because it has spread it somewhere else. Now, if you did your screening like I recommended, save your butt at 30, and we found blood in you at 31, you took it to your doctor, he performed a colonoscopy on you. Most likely he's going to find cancer in the very early stages. There are 4 stages to cancer. First, it's just in the mucosal layer, which means it didn't penetrate at all, not deep at all. You have a 95 to 100% chance of living like anybody else who never had cancer. But if you get stage 4, that means it's already in the liver. That's pretty late. You have about now between a 5 to 12% chance of living. That's just the fact. But if you catch it in stage 1 or 2, you have a better chance. That's probably when we like to catch it. Well, we like to catch it earlier than that. But if we catch it in stage 1 or 2, then you're close to about 80 to 85% chance of living 5 years. That's very favorable numbers. So it's all, when do we catch it? That's the whole point. So if we catch it early, you have a very prognosis. You catch it late, you have a very low prognosis.
All right.
So cancer caught early is treatable and curable for that reason.
Okay. So explain to our viewers what a polyp is. You know, you hear, because here's the thing. A lot of times people will go into physicians and they're talking on this level, and we need to bring it down. So people want to know, all right, what do you mean I got a polyp? What does that mean? What is a polyp? So in, the simplest of terms, tell our viewers what a polyp is and why is that significant?
Okay, a polyp is nothing more than a growth. And we call a growth a neoplasm, because neoplasm means new growth, right? And polyps are broken down in certain categories. You can have a hypoplastic polyp. That's nothing. That's like a pimple. You can have an adenomatous polyp. That's nothing as well either. But now when you mention the word villus, now the cells start changing its cell type towards cancer. So if I use the word tubular villus or pure villus, that's closer to cancer. Now we have a concern. So if you catch a polyp early, hypoplastic, it's nothing. You have a regular adenomatous polyp with no villus component, that's nothing either. But once you start talking about the word villus, because it's been in your body a little bit longer, now we have more of a concern. So that's really the concern. You don't want a villus polyp, you want to catch it early. When I'm performing an endoscopic procedure, if I see a polyp, I cauterize it, I take it out, we send it to the lab. The lab will come back saying hypoplastic, everybody's happy. The lab will come back saying it's an adenomatous polyp, everybody happy. Or the lab might come back saying, oh, you have cancer in the head of the polyp, but I cut it at the tree trunk. So I want to know what happened at those cauterized margins. Is there any cancer left in the patient? If they come back saying no, then we took the cancer out of you. Mm-hmm. So it's all when we catch it. That's the point.
Yeah. Okay. So let's switch gears a little bit and let's talk about some factors that maybe a person should really consider when it comes to getting screened for colon cancer. The first one that comes to mind for me is, let's talk about ulcerative colitis. Let's talk about that, because people get diagnosed with that and not really understanding what does that mean. That's a factor. So, your take on having ulcerative colitis.
Well, any of the inflammatory bowel diseases, whether it's ulcerative colitis or Crohn's colitis, needs consideration because they are more prone to go towards cancer. People with those kind of diseases. And people who present with ulcerative colitis, which is diarrhea and bleeding, we perform an endoscopic procedure on them, and we find that they have ulceration all the way through their colon, or maybe just the left side of the colon, or maybe just in the rectal area. So there's degrees of ulcerative colitis. And we screen those patients more often looking for changes in the tissue type that goes towards cancer. Same with Crohn's colitis. Folks with Crohn's colitis, we screen them more often. We're looking for cancer. So those are the two that we're concerned about. There's nothing you can do about it because either you have ulcerative colitis and Crohn's colitis or you don't.
Okay. So the people who suffer from IBS or irritable bowel syndrome, does that kind of fall into that category as well?
No, it doesn't. Irritable bowel syndrome is more of a psychosomatic, in my opinion, issue. Probably the most common GI problem that we see in the office with the bloating, the pain, the diarrhea, the constipation, right, or the mixed presentation. But that does not necessarily lead to cancer. What people don't talk about when I read the literature, you never hear the word stress and associated with cancer of the colon. You don't hear it. You don't hear it. I'm telling you, you don't hear it. Nor do I read it. And people that I serve are under a lot of stress. Maybe that's true with African American too, by the way. we're under a lot of stress, which might lead to colorectal cancer, but there's no association. We make clear when you read the literature, you don't see that association. This is me saying my opinion from what I have seen in my patient population, that stress plays a big role here.
Well, it seems like stress plays a huge role in everything that we do.
Isn't it though?
So, look, I'm looking at double whammy, black, male, female stress, all of
Hello.
those things. But this is educational. So we have a couple of other questions from viewers. They wanted to know, so every polyp found in a colonoscopy, the question is, should it be removed?
Well, look, as a colonoscopist, I'm a hunter and I'm hunting for problems. And if I see a polyp, I will remove it because I know it has no, it's not there to help you. It's there to hurt you. And so we will remove every polyp that we see. The kinds that we don't see are probably the sessile polyps because they're flatter. The polyps that grow like a plant will grow, we see those real easy, but the sessile polyps are more difficult to find unless they reach a certain size, like 1 centimeters or 10 millimeters. They reach that size, they're easy to see. But if they less than that, we might miss those because they're flat. But yes, if I see a polyp, I will take it out. Every one I see, I will take out. Absolutely.
Okay. All right. So I want you to just marinate on this. We're going to pause for a cause because we got to pay the bills. And when we come back, one of the viewers asked this question. So for you to think about, what, if any, are the percentages of patients who will have a reoccurrence after treatment? So when we come back, I will broach that question again with you. And in the meantime, you guys, thank you so much for hanging in here. We will be right back. All right.
Show some respect. Show you give a damn. Show the world how it's done. Show them that when your community needed you the most, you showed up. Mask up, America.
Let's get back to talking smack with the side of mac and cheese.
Before we can safely come together, we need the facts on COVID-19 vaccines.
To get the facts, visit getvaccineanswers.org so you can make an informed decision when vaccines are available to you.
All right. If you guys are just tuning in, you are tuned in to You Didn't Get the Memo Show. And I have as my guest Dr. Ralph Peterson, who's a gastroenterologist. And we're talking about colorectal cancer. Before we took a quick break, one of the questions that one of the viewers asked was, what, if any, are the percentages of patients who will have a reoccurrence after they've received treatment for colon cancer? Dr. Peterson?
So we really have to talk about the stage in which we caught that problem. If you caught stage 0 where it didn't penetrate the walls at all, it's not going to reoccur. It's gone. We removed it. If it's stage 3 means lymph nodes involved. And there's 2 types of stage C. We call it stage C, where lymph nodes are involved. So it depends on how many lymph nodes involved. We may not get all of them. We may think that we have gotten it. You may have had surgery, you may have had chemotherapy. And that's why we keep constantly following you with the CEA antigen. That's the chorionic embryonic antigen that's looked for. It's one of the biological markers for colorectal cancer. So if you have cancer and we did the CEA level on you, and everybody should have a CEA antigen level done on them. If it's elevated, we do surgery, it goes down, then we just follow that level. If it comes back up, we know that you may have reoccurrence of colorectal cancer. So it depends on what stage we catch you. If you catch you in stage 0 or 1, you're probably good to go. But you start talking about 2 and 3 and certainly 4, I think we have a problem. Yes.
Okay, good. Thank you. You guys keep your questions coming. This is a great opportunity, and let's utilize the expertise with Dr. Peterson. So, Dr. Peterson, you talked about, there are certain risk factors as it relates to increasing someone's chances of getting or developing colon cancer. The question is, what role, because you kind of alluded to it a little bit, what role does diet and exercise play in patients developing colon cancer? Because we know there is just a plethora of things that people talk about that we need to do. But let's just focus right now on diet, because we know the diet that we probably were accustomed to growing up, being Southern, and how we eat. Now what we see, everything is maybe fast foods and that type of thing. But is there a correlation between diet and exercise and colon cancer?
Yeah, there's a huge correlation. Whether it causes it or not, but the correlation is there. We tend to see more colorectal cancer in folks who eat less fiber, so they're fiber poor. We see colorectal cancer more in folks who eat more animal meat than folks who do not. Folks who are inactive, we tend to see colorectal cancer more frequent in those people who are inactive, those that are overweight. So these are modifiable factors that you can do. Heavy drinkers, smokers, you see colorectal cancer more in that group of folks than people who don't smoke or people who don't engage in heavy alcohol use. So those are the modifiable factors that you should pay attention to. Listen, this is a body. Take care of your body on all levels. That's the point.
Yeah.
And when you do that, the real question is you need to be screened. Even when you do those things, you still need to be screened. That's very important. I'm recommending 30 with the fit test.
Okay. And I mean, my head is going because as you age, as you get older, it seems like there are things. But what we're trying to do here, you guys, is to educate you so that you will be proactive early on. So if you've got a loved one, this is truly what you want to do. You really say you love somebody, why wouldn't you do this? And we've got a couple of comments. I'm going to show that. They love the fact that I know what gift my loved ones are getting for for Christmas. I love that. But also we had someone say a good reason to de-stress as much as possible. Those are things that are, I think, that are paramount to just overall good health care. But I want to go back to something that you said, being overweight, drinking, smoking. But what about those people that are sedentary, that suffer from, they have hemorrhoids? And, are all of these things kind of intertwined? What are your thoughts? Because you're telling people a lot of things that they really need to do. And it's important. So what I'm hearing is, y'all, we need to be moving. We need to be eating healthier. We really need to get into this routine, and we need to be tested. So you're thinking the scientist.
No, I'm not thinking. I'm gonna come at it this way.
Okay, come on.
I was reading somewhere in the book of Romans, 12th chapter, I believe, verse. Says, "I beseech you, therefore, brothers, by the mercy of God, that you present your body as a living sacrifice." So we have some work to do to keep our body as healthy as we can. And only we have control over that. Yes, we have a lot of stress. I tell everybody, take as many breaks as you can. My wife and I, we try to take a break twice a month. People say you have money to do that. I'm not sure that's true, but we do it anyway because we know all the kind of stress that we have to deal with. I've told patients that, and they've done it. They come back to me. They feel much better in life. They have a better perspective because stress is what we deal with. You need to de-stress. So we have an obligation to take care of this temple that we have the best way we can. And if you're concerned about colorectal cancer, the best thing to do is, exercise, cut back on your meat consumption, eat more fiber, more God-produced foods. Don't be inactive. And when you still do all that, still get screened at 30. If you start at 30, you're ahead of the curve. You can do something that is preventable. Like I said, if Chadwick had gotten screened and somebody told him to get screened and nobody was telling him at that time, because we said 50 at that time and now we're down to 45, but that's too late in my opinion. We need to be screened early. And that's very important.
Yeah, absolutely. And thank you so much for just really expounding on those particular things because they just really want to pound it home. I know a lot of times the PCPs or primary care physicians, they tell you, oh, you need to get a little more exercise, you need to do a little more of this. But I just find that as we continue to age, there are a lot of things that is involved in that too. And part of that is just building healthy bones and strengthening yourself, as well as, and a lot of people think, oh, I can't do that. But like you said, it's not about whether you have the money to do it or whatever. It's all about time and it's about self-preservation is what I'm hearing you say. And that's
Yes.
really what it comes down to. So we're going to take another quick break. And when we come back, I just really want to go back to you talking about biomarkers, Dr. Peterson. So you guys don't go anywhere. Keep your questions coming. We appreciate it. And we will be right back.
Thank you for watching the You Didn't Get the Memo show with your inspirational host, Gloria Bailey Ray. It's your contributions that make this happen. To become a sponsor, send an email to youdidn'tgetthememo@gmail. That's the letter U, didn't get the memo. If you're not in a space to be a sponsor, but you like what you hear, we simply ask that you support what you like by making a contribution to the show. There are 3 ways to make an online donation. Visit paypal.me/Gloria Bailey Ray or Cash App or Venmo, Gloria Bailey Ray. Give what you can. Your support is appreciated.
All right, you guys, you have been tuned in to You Didn't Get the Memo with my wonderful guest, Dr. Ralph Peterson, and we've been talking about colon cancer. Before we took that quick break, one of the things that I asked Dr. Peterson was to let's just circle back around. I really want to make sure that everybody gets this, and to explain again, when we're talking about biomarkers, what are biomarkers as relates to diagnostic, as relates to prognostic and predictive? So Dr. Peterson, can you take us through that when we're talking about someone goes to their doctor and they talk about a biomarker and the people walk out with the deer in the headlight, look, they have no idea what they're talking about. So will you expound on that for us, please?
Yeah, we have biomarkers for like liver cancer. We might do an alpha fetoprotein test. It's a biomarker. So if it's elevated, it suggests something. For colorectal cancer, we do a CEA antigen. If it's elevated, it suggests something. If you have a uterine cancer, CA19-9, if it's elevated, or cancer of the pancreas, it suggests something. And then we begin to hunt and find out what is it that it suggests. Is it true or not true? So for the biomarker for the colon, it's a CEA antigen. I've seen a negative in a lot of patients who have colorectal cancer. When my mother passed from colorectal cancer, her biomarker was in the 100. Now, 4 or less is normal. She was in the 100. So they did surgery. It dropped, not to a respectable number, to like 50, but then it started climbing again, which meant that the cancer was still there and spreading. So that's the purpose of biomarkers, particularly for colorectal cancer.
Okay, we've got a few questions from the viewers. The first one is, can you repeat the name of the lab where you can order the colorectal test?
Pinnacle, Pinnacle, Pinnacle Biolab.
Okay.
It's pretty good. Most of my friends go there on site, order it. I've ordered it. I've done it on myself to make sure. And I've also done the Cologuard. The Cologuard is another test. It's a Pinnacle test. It's a FIT test, but it's multi-targeted because it looks at DNA abnormalities as well. So it's a little bit better than the FIT test by itself. That's a more expensive test. Then you start talking about between $300 and $400, $500. The price of a colonoscopy almost. But the FIT test, once again, is about, you get 2 of them for like $29, pretty cheap test. So, and it's worth getting. Yeah, it's worth getting and worth doing.
Okay. All right. Another question from the viewer is, what approach should we take in dealing with the primary care physician who compiles solely with the insurance company and I think complies solely with the insurance companies who say when a screening should be conducted. So they're saying, what should be their approach, especially if they know they have family history or they've experienced some of the symptoms that you have mentioned, and their PCP is basically saying, well, this is not what's recommended based upon your insurance plan. So what do you say to those viewers who may run into that?
So here's what happens. The American Cancer Society said that 45 is when we should be tested. When they said that, that means the insurance got nervous because they know they had to pay for it when doctors started requesting testing at 45 when it was 50. The United States Preventative Service Task Force also came along later this year, in fact. Remember, American Cancer Society did it 2 years ago. The United States Preventative Service Task Force came along and said, okay, we agree, you can go to 45 with average risk. So the insurance now are forced to pay for it. I say to you, this is not about your doctor. It's not about me. This is your butt. Your butt is on the line, not their butt. So you can go to Pinnacle, do the test. If it comes back positive, you can take that positive test to the doctor. Believe me, they're going to do what's necessary to find out why that test is positive, because you know why. We got to do what we must do because we don't want to be sued. Number one. Number two, because we want to find out why was that test positive? Was it a false positive or not? They might repeat the fit test, but the insurance will pay for that because now you have reason. Or maybe you might be anemic at the same time to do a complete blood count. So it justifies start to looking why you are anemic. And by the way, colon becomes one of the first sites that people look for anemia, particularly iron deficiency anemia, because I get awful lot of patients sent to me saying the patient's anemic. Could be other reasons, bone marrow problem, not enough iron, bleeding from somewhere else. But colon is what we look for first, and then the stomach. So it's not about the doctor. It's really about you. It's your butt's on the line. So order the Pinnacle test, starting at 30. And if you're older than that, you can, if you don't want to pay for it, just tell your doctor, I need the Pinnacle test. I need the fit test. I want to find out if there's any blood in my stool. A reasonable physician will listen to that, and insurance will pay for it as well.
Right. Well, I think the operative word is reasonable physician. But the bottom line to the viewer that asked that question, as Dr. Peterson said, it's all about you. It's not about them, because they're not the ones that will have that diagnosis and have to deal with it. And thank you for seeing that, because a lot of times we just feel like that doctors, whatever they say, we just kind of march, and just go by what the rules are. But your body better than anybody else. And if you've been feeling a certain way, if something just hasn't felt right. And I always say, this is my body. So if it's my body and I'm saying I'm having these symptoms, then, Dr. Peterson isn't saying this, but I'm saying that you might want to consider finding another physician, because at the end of the day, my attitude is that we should work, together. It should be a team effort. It shouldn't be you just dictating, I want to participate in my health care. I want to be a part of what's going on. And I think that that's really important. So, Dr. Peterson, you've covered just a plethora of things. And let's see. Yes, one of the comments from our viewers is that we must be proactive. I agree with you about our own health care. And I think that that's really, really important. Thank you so much, Ms. Deborah, for that. So with that, one of the things that I want to ask you, Dr. Peterson, in this short time that we have left, what is it that you want people watching the show to take away? What are some key points or highlights that they need to be aware of?
We must be outliers. An outlier is one who don't conform to what the rules say that we should do about our health. Somebody else is telling us that we should start at 45 or 50. I don't know what that means, because they're not dying. I'm concerned about me, my family, my wife, my kids. And so therefore, we know that 1 out of 24, if 24 of you listen to one of you, going to get colorectal cancer. So you want to know sooner than later, because the sooner you know, the better we can treat you and the more likely you will survive that. It might just be simple surgery. It might just be a removal of a polyp. In fact, they got a new technique we call endomucosal resection, where we perform an endoscope and we just scoop out the lesion, just scoop it out. I don't know how to do it, but they know how to do it. And I send my patients for those procedures as opposed to getting cut on. externally. So it's about your health. Screening is the most important. If I had to leave anything, you don't have to know anything else but screening. Start at 30 with the fit test. Do it every year on your birthday. Every birthday, you want to save your butt another year, another year, another year. And when you get to 45, you would have done maybe 15 of them. So by the time you're 45, you're ready for a colonoscopy. Really don't expect to find anything. And then you wait 10 years later, do your next colonoscopy. But between that time, 45, 46, 47, 48, on your birthday month, continue doing the fit test. So it's an annual test.
Okay, awesome. So, Dr. Peterson, I first of all, I want to thank you so much for being on the show and for, sharing all of this information because it's information that people need. Now, I know that in February, I think that's a colon cancer screening month. Is that correct? Is it in
February,
February?
March, yes. Mm-hmm.
Yeah, okay. So, we're going to invite you back and have you on the show and probably get a little more into it, a little more didactic, and talk about what people are looking at and all of these different things. I would love to have you come back and we talk about that. In the meantime, for those of you who actually, I see a lot of times people will post after the show is over. So if you have questions, I will share those with Dr. Peterson and I will make sure that we get get an answer, a response to you. All right. So again, Dr. Peterson, I want to thank you so much for being on the show. Don't you go anywhere. I'll be back with you. But what I do want to say to our viewers, first of all, thank you guys so much for tuning in. I want to thank my guest, Dr. Ralph Peterson, for being on the show today. Here's the gentle reminder, and that is to ask you to remember to support our efforts by inquiring about our sponsorship package opportunities, or if you'd like to be a supporter. If you're not in the space to become a sponsor, you can still support by making a donation of any amount. Just remember, there is a blessing in the giving. Today's show again was sponsored in part by Ms. Joyce Van Hoof of Golden Memorial Insurance Services. I want you guys to be sure and follow me on all of my social media platforms and mark your calendars for every Tuesday, 5 p.m. Pacific Standard Time for another great show on You Didn't Get the Memo. If you're in need of some midweek inspiration going into the weekend, hey, you can be sure and tune in to my podcast, Real Talk with Lady G, on Spreaker. That's Spreaker, Spreaker.com. That's every Thursday at 6 p.m. So again, I want to give a quick shout out to all my viewers, donors, sponsors, and thank you so much for your support. So as I always say, if you didn't take anything away from today's show, then it's really you who didn't get the memo. But I want to wish all of you a great week. Thank you all. I'm sending you abundant blessings. Stay safe, mask up, get vaccinated, and always remember to pay it forward. Remember this, the quality of your life is determined by the decisions that you make. I'm your host, Gloria Bailey Ray. You've been tuned in to You Didn't Get the Memo show. Be well. Peace out.